welcome everybody here and acknowledge that I personally am joining in from the traditional and unceded territories of the Coast Salish people, so colloquially known as the Surrey and North Delta area, and I'm really proud and honored that I'm able to share this land. Few housekeeping items to go over with everybody. So as I mentioned, if you are comfortable, please, we encourage you to turn your cameras on. We like to see all of your guys' lovely faces. Your name on your screen, if you are able to, we encourage you to change your name. You can see mine here. It says April Denise. It just helps us keep track of attendance so that we know who to send our lunch gift cards to. So please change your name if you can. There is a chat box, as there always is in these Zoom questions. So if you have any questions for the Jim Pattison team, please feel free to put it into the chat box. There will be a short question and answer period at the end of the session, so you can raise your hand if you have a question. We do acknowledge that we may run out of time for Q&A. We might not get to everything, so there will be a formal Q&A document that gets sent around to everybody a couple of days after the session. So if your question doesn't get addressed today, we will certainly be addressing it in the Q&A document. And then at the end of the session, please watch in the chat box. I'll be putting in a very brief 5-question evaluation. It's really quick and easy, but you do have to complete the evaluation in order to receive your DoorDash gift card. And so with that, I'm going to hand it over to the Jim Pattison team and say welcome, and we're so happy to have you here.
Thank you. Are we? Yeah. Okay, I'm just going to share. Oh, let's share the screen. Okay, is that good? Can you hear us and see everything? Yeah.
Looks good from this side.
Okay, my name is Kim Lowry. I'm the manager of the Breast Health Clinic, and here is Jazz Penang. Am I saying that right?
Yes, Penang.
I should have done that beforehand. And she's the supervisor of the mammogram
Department. Yeah.
Here's the housekeeping. We've done that. Okay, here we are at Fraser Health. We'll start off, and then we'll sort of tag team it.
So our presentation objectives today are to review screening and diagnostic mammography services, breast health clinic service overview, eligibility guidelines, how to book a screening mammogram or make a diagnostic mammogram referral, how to make a breast health clinic referral, screening mammograms versus ultrasounds, common issues with referrals, how are referrals triaged, the patient journey, and contact information and locations. So for the mammography services overview, for screening mammography, we perform 4 standard X-ray images of the breast. Screening mammography is used to detect breast cancer changes that could be cancerous in people who have no signs or symptoms. The goal is to find cancer when it's small and treatment may be less invasive. Regular mammograms can lower the risk of death from breast cancer. For diagnostic mammography, we perform the same 4 standard X-ray images to investigate suspicious findings such as a lump or abnormality detected by a screening mammogram or physical exam. We may perform additional views at that time or call back the patient on another day to perform additional tests. Diagnostic mammography focuses on obtaining information in a specific area of concern. With both streams, includes the same standard 4 images, so we're using the same equipment, same units, and same 4 standard images. Diagnostic may require additional images, and the report format is different. So screening is an automated report, whereas diagnostic is a dictated report. So for the next slide, we're going to review screening mammography eligibility guidelines. So any patient that is 74 and above will not receive a reminder from the BC Cancer Breast Screening Program. They will have to keep track of their frequency of exams, and you can book every 2 to 3 years without a doctor's recommendation or referral. Average risk patient, which is 40 plus, can book every 2 years. There's no risk details like family history or anything, and they will get a reminder in the mail when they are due for their next mammogram from the screening program. Above average risk patients that are 40 plus should be coming in every year for their mammogram. And these patients are have a family history with an immediate family member that has been diagnosed with breast cancer. So that would be mother, father, sister, brother, daughter, son, half sister, or half brother. Also, patients that fall in this category are also patients that have been diagnosed with ADH, ALH, or LCIS previously. And the last category is high risk. These are patients are 30 to 39. They should be imaged every year. I have a screening mammogram every year. And these patients have the gene variant, they're positive, they have a strong female family history, and or they've had chest radiation between the age of 10 to 30.
Kim,
So-
I'm just going to quickly interrupt. Just for some of the people in the call, there was a really quick question in the chat. What is ADH, ALH, and LCIS?
They are like precursors to breast cancer. So they're abnormal cells that may develop into breast cancer. So these patients have had a biopsy. They've had that area removed, but they are at higher risk than an average screening patient.
So the precancerous cells.
Yes.
Thank you.
So how to book a screening mammogram. So patients that are 40 and above don't require a referral. They can call the booking line or book online if they are a previous patient, a screening patient. Anybody that's 30 to 39 will require a pink slip referral from their doctor that needs to be completed, and they are to bring that pink slip with them at the time of their screening mammogram appointment. Patients can self-book, first come, first serve appointments. First time bookings must be over the phone. So if you're a patient that has never had a screening mammogram before, you need to book by phone. By calling either the 1-800 number or any one of the sites listed on the pink slip. And online bookings only available for those patients that have had previous screening. They will receive a reminder in the mail with a booking code, and they need that booking code to book online. So the next section is benign causes of breast pain. We do receive many referrals for breast pain through the diagnostic mammography department. And these are just some of the reasons for breast pain that are benign. And so it's important to review with your patients to understand that the pain they are experiencing is focal, like in one area, is persistent, and it's greater than 12 weeks. If it's intermittent pain, or, it varies in location, it can be caused by hormones, larger cup size, ill-fitting bra, lower levels of fitness or activity, fibromyalgia, cysts, periductal mastitis, stretching of the Cooper ligaments, fat necrosis, previous surgery, Mondor disease, diabetic mastocytopathy, duct ectasia, musculoskeletal disease, referred nerve root pain, herpes zoster, heart disease, biliary pain, or peptic ulcer. So when to refer for ultrasound instead of a mammogram? So patients should be referred to ultrasound if they're 30 and under, if they're breastfeeding, pregnant, if there's been a lesion seen on a mammogram and an ultrasound is recommended, if there's a true palpable lump, or if a patient's had a bilateral mastectomy and there's an area of concern that needs to be investigated. What can't be seen on ultrasound are microcalcifications. We do not perform screening ultrasounds for breast density. And if there's no new symptoms or follow-up, we would not be performing an ultrasound.
Oh, I think it got muted accidentally there.
Weird. Okay.
Go ahead, sorry.
Hi there. So for
Okay.
the screening mammography patient journey, the patient will book their appointment. They will attend at the site. The screening mammogram findings are reported by a radiologist. If the findings are normal, the results are sent to the patient and the family doctor. If the findings are abnormal, the patient will be booked for additional imaging, and based on the results of that imaging, we may refer the patient to the breast health clinic if they require further care. It's a direct referral to the breast cancer, so we don't need an additional requisition. And here's the screening mammography contact information. The Jim Pattison Outpatient Care and Surgery Center. There is the address there.
Yeah, I know.
Yeah. Okay, and so how to make a diagnostic mammography referral. The referral forms can be found on the Fraser Health Medical Staff website. There's a link right there. And it's always better to utilize the link or use the link because it has the most recent requisition available.
It's also on Pathways.
Yeah, it's on Pathways. Okay.
Does that include the pink slip referral also?
No.
No.
So there was a question in the chat about where do they get the pink slip referral form?
That would be from the BC Breast Cancer Screening Program.
Thank you.
So when to make a diagnostic mammogram referral. So it's new onset of symptoms, which would include a new lump, thickening, bloody discharge, dimpling, contour, deformity, retraction, new nipple inversion, swelling or redness that affects 1/3 or more of the breast, a pitted skin, a screening abnormal finding, or an investigation of a CT MRI finding. Also, if we're following up findings that are categorized as BI-RADS3 implants, patient that's had a previous breast cancer, or patients that do not qualify for screening that have a family history. And so here are some common referral mistakes to avoid. Sometimes we will receive incomplete requisitions where we have the reason for exam missing, hormone therapy, surgical history. There's a checkbox for proceed to further imaging. If this is not marked, it'll delay the booking. mammogram history with the date and the location of the previous mammogram, and family history, which would include the person that was diagnosed with breast cancer and the age. It's really important to mark or stamp the requisition as urgent if there's a high risk of breast cancer symptoms, or and also if there's we found that doctors or offices are sending referrals to multiple sites, and this can be difficult because, you know, two sites might book the patient at the same time, and sometimes the patients don't know to cancel like one of the appointments, and that they're, you know, the same exam or test. And also, if a patient is having diagnostic mammography routinely, they should be seeing their doctor, or the doctor's office should be sending the requisition several months prior to when they're due, so that they can get in at the 1-year mark or the 6-month mark for follow-ups.
I just want to quickly clarify something that came out in the chat. There was a point of clarification that was asked. Dr. Kumar is wondering, did you say patients do not qualify for screening if they have a positive family history?
Yes, they do. It depends on the age. So if they are 30 to 39, on the pink slip, there is criteria that needs to be met for family history. I believe you have to have 2 family members under the age of 50 that previously had been diagnosed with breast cancer, and then they qualify. But they do need the pink slip to be completed and brought with them. If they're under 30, they must go to diagnostic mammography, unfortunately.
Thank you for clarifying.
So diagnostic mammography, we will receive the diagnostic referral. The radiologist will triage the referral. The patient is booked for the appointment, and the patient will attend the appointment. If the findings are normal, the patient will follow up with their doctor and return to routine screening intervals. If it's abnormal findings, the patient will be booked for additional imaging. And at this time, if the patient is suspected of having breast cancer, we do try to refer to the breast clinic ourselves, if possible. If that's not possible, then the office, the GP's office must provide a requisition to the breast health clinic so that patient can be seen by a specialist.
And I'll just jump in there to clarify a little bit, because it is confusing. If it's the screening mammography and there's findings, they automatically will get referred to the breast health clinic without a referral. But just to make it confusing, if it's been a diagnostic mammogram that's been referred, the GP has just simply requested it, and then something's found on it, we'll get it. But if it's like a really high risk, medical imaging will walk it over and say, hey, you need to see this patient, and we will see them before we get the referral, but we actually still need that referral. So depending on how urgent it is, sometimes we will wait for the official referral to come. Sometimes we'll see the patient first and then let the doctor know, hey, we've seen your patient, but we need a referral. So if we're asking for a referral, it's because we've seen the patient, but we still actually need that, even though it's after the fact.
Yeah. And here is the contact information for diagnostic mammography. There's the phone number, fax number, and the hours of operation.
Okay. So I've got the breast clinic. So basically, we're a specialized breast care clinic. So we see patients that have breast concerns such as lumps, bumps, skin changes, unusual imaging, and also something that's kind of popped up, which is called granulomatous mastitis. So if you have a patient that has like almost like an ulcerative and fistulizing breast, and it looks like an infection in your you know, they're getting treatment, antibiotic after antibiotic, and it's not responding, it very likely is something called GM, which is growing in popularity, unfortunately. And if you refer to the breast clinic, we can usually diagnose it pretty quickly. And it's treated with anti-inflammatories rather than antibiotics. So those are the kind of things we see. We are streamlined, which is so we can sometimes get expedited access to services. We work really closely with medical imaging and you'll try to collaborate together to get things done when things are highly suspicious. Just another thing about us is we do follow something called the USOMA guidelines, which is a European-based, almost like a think tank and quality process, where our goal is from suspicion to diagnosis is 21 days. And that's not necessarily diagnosed to cancer. It could be like, you don't have cancer, yay, but it is like in 21 days, we'll have you sorted out. That's our goal. So we see all genders. If you have genetically positive testing, we'll see. If your screening results are abnormal and it looks like you're gonna need a biopsy, it gets sent to us. Previous cancers, but with new symptoms, we don't do the surveillance. Family doctor, so if you're really concerned about a patient and you give us a call, we'll see the patient. So we don't, like I said, don't do surveillance. We don't do breast implants or post-cancer surveillance. We don't do any sort of augmentation type complications that you would go back to the plastic surgeon. So just like medical imaging, you can get our referral forms on Pathway or on the medical staffing at the Fraser Health website. So it's kind of the same. So this is our referral form, and I've highlighted a few things that are really important. This first one here is the phone number. So we get a lot of referrals with the wrong phone number. So we're trying to contact the patient and we can't. So that's super important. It seems like a no-brainer, but to have an updated phone number, super important. We also decide how we're going to see your patient based on what's ticked off here, what's written here. So these next two circles are super important because we have a bit of a triage system that will get your patient in, within a week or, 4 weeks, but it depends what's written here. If they've had previous images, you don't necessarily have to send them if they've been done in Fraser Health, but we do need to know when and where they were done. So these are really important things to help us sort of expedite things. So how we see patients, how we triage them is based on that document that you would send. So if it's low suspicion, like just a generalized breast pain, there's discharge, but it's not bloody, they're less than 25 years old, we're going to do our best to see them within 4 weeks. If it's kind of modern suspicion, like they've got a lump, something needs some imaging, then we're going to see them in less than 3 weeks, if possible. If it's highly suspicion, like a report says that they need a biopsy, or there's, the GP phones and is saying, I'm really concerned, I don't know what's going on, there's bloody discharge from the nipple, there's the skin changes, all that kind of stuff that Jazz talked about earlier, we're going to get them in within 2 weeks. We may or may not be booking additional tests prior to that appointment. We try, but it's not always possible. And then if it's a confirmed cancer, an emergency situation, highly suspicious, it's coming up as a BI-RADS 4C or 5, we're gonna get that patient in, within a week, as soon as we possibly can. And these are the ones that I was saying earlier that, especially if they've picked it up through diagnostic, that they're a BI-RADS 5, they will walk it over to us to be like, you need to see them. And then those are the ones that we're like, we've seen your patient, but we need a referral. So that's those ones. So our patient journey, it's kind of similar. So referrals received, it's triaged in one of those 4 categories. The patient's booked for an appointment. They may or may not have their diagnostic mammogram before the appointment. That's ideal. That is not always possible. It's just the demand is really high and there's only so many spots. So the patient attends the appointment. They will always have, so this is where our clinic differs from clinics in the rest of Fraser Health. They will always have a consultation with a surgeon and a physical exam or with that surgeon and a nurse. And then from there, it's decided whether or not further testing is needed. And if it is, then based on those results, is it further monitoring? Are they referred directly to BC Cancer Agency? Or are they referred for surgery? Those are sort of, and then our new sort of thing with the GM is we will refer them to Dr. Erican over at RCH for infectious disease. This is all our contact information. And again, like if you're really concerned about your patient and you really feel they need to be seen sooner rather than later, a phone call is kind of all it takes, and we'll do what we can to get you in. We do have some future initiatives that I wanted to mention here. We are working on a website and a portal. We've sort of applied to the Share Carrot initiative, and we're hoping that this will address a lot of the questions that were sent in with, like, what do I do with hormone therapy? What do I do with lymphedema? All of that kind of stuff would be here. So there would be area for patients to go to for their own information, and then like a portal for healthcare professionals as well. So that's kind of up and coming, and that is us in a nutshell. Happy to answer any questions.
Perfect. Thank you, you guys. I've got a few questions here in the chat. First one is from the screening mammography section, although it probably applies to both. Sorry, I just bumped it. What would be considered an urgent referral and a non-urgent referral?
So for screening, there is no urgent or non-urgent. It's first come, first serve, patients with no symptoms, no issues. For diagnostic mammography, it would be somebody with like an example would be firm, non-mobile lump, retraction of the breast, like it's pulling in, skin changes, bloody nipple discharge.
The orange peel skin.
Yeah, the orange peel look, like the pitted skin. Sometimes there is inflammatory breast cancer, so the whole breast will be like red and swollen and uncomfortable, painful for the patient. So that's another one.
And honestly, if you're having those issues, refer to the breast clinic.
Yes.
don't try to get all the tests. Just refer to us.
Yes.
And let us get that coordinated for you.
So that, I guess, kind of addresses one of the other questions in the chat regarding would it not save time by referring directly to the breast health clinic for any questionable exam? It sounds like yes, that would probably be faster.
Yes, and like patients with previous breast cancer, no symptoms, family history, no symptoms, follow-ups, 6-month follow-ups, no new symptoms, can all go to diagnostic mammography, where we can book them in, and based on their report at that time, then if there is a further recommendation, referral can always be made to the breast health clinic at that time.
Yeah, but just to be clear, like generalized pain,
Yes.
that would just be diagnosed. That wouldn't be, or that would be screening. Sorry, yes. Not even, that wouldn't be a breast health. Like if, oh, my boob hurts, that's really not either of us. That's screening.
Yes, yeah. If it's a definite focal area greater than 12 weeks, persistent pain that does not stop, then definitely diagnostic mammography can be considered. But otherwise screening is recommended for those patients.
Thank you. So we are at 1 o'clock. In the interest of everybody's time, there's quite a few questions in the chat. So I just would like to share with the attendees that the breast health clinic and screening mammography, they're going to take back all of the questions that were shared in the chat. And there was also some questions that were submitted prior to the session. They're going to put together an FAQ document, and it will be shared with all of you guys along with the slide deck that you saw today. So with the contact information attached to it, we will share that back with all of you. I wanted to just say thank you to everybody for taking the time. We had a really full house today, so thank you so much for taking the time over your lunch hour. And then to the Jim Pattison team, obviously our gratitude. The evaluation link has been put in the chat, so please take a moment to quickly fill that out. I'm going to pop it in there again, just so it's the first one that's there that you see. As soon as you're done the evaluation, you are free to leave the session for today. And again, extending my thanks and gratitude to all of you for coming and sharing time and space with us today.
Could I ask a question, please?
Thank you.
Sure.
Of course, go ahead.
I just want clarification, Kim, about the referral for diagnostic mammogram. Family history positive, but they are asymptomatic, or they have fibrocystic disease. Can they go for diagnostic mammogram?
They should be going to a screening mammogram.
Okay.
Yeah, we perform the same 4 images, but diagnostic mammography is specifically for patients that have new symptoms, require follow-up as per previous report. Implant patients, they follow the same screening guidelines every year with family history every 2nd year, if no family history. Yeah, so those basically are the ones that should be seen in diagnostic, and all others should go to screening.
So that's where I misunderstood, as you said, family history positive should go for diagnostic.
If they're under 30.
Okay.
Yeah, and if they don't qualify for screening, there are screening guidelines that are describe who and at what age family members that have breast cancer. With that history, you can review the pink slip and it'll state on there who is eligible and who is not. If they are not eligible, then they can go to diagnostic. A patient, if a patient's mother, sister, father, son, half sister, half brother have breast cancer, the patient should be getting a mammogram 10 years prior to the year of diagnosis. So if a patient's mother was diagnosed at age 35, the patient should start mammography, at 25. Yeah.
Good. Thanks for clarification.
No worries.